So I'm really excited to be part of the mobile clinic and hospital at home project because it's something I feel like the community really needs and has needed for a very long time. I've always kind of dreamt of working on a mobile clinic on the reservation. I've pitched it to several employers, but not gotten a bite on it in my various places I've worked. So I was really happy that Kamau had this project going. Um, and when I applied, so I was just really excited about it. In terms of the community needs, I think that there's a lot of reluctance to engage with healthcare, and I understand the reasons for that. We are really trying to meet people where they are and provide the services that they need in a way that is acceptable to them. Culturally and just person to person. You know, we're not coming into people's houses to do anything but deliver care and be a resource for them. So it's just really an honor to be able to do that. I think that in terms of hospital to home, the services that we provide can be, you know, as small or as big, you know, as we need to go, you know, really, you know, small services would be just like, you know, checking on maybe an elder's skin condition and taking care of maybe needs that they might have for durable medical equipment or connection to other services. But big needs through the hospital home program are going to be more like trying to take care of them as if they were in the hospital for a brief admission, to take care of like a urinary tract infection that needed antibiotics, for example, or pneumonia that needed antibiotics.
Talked about those potential staying after clinic hours as we grow with staff. We have to build up our footprint first, but ideally trying to stay open until around 8 in the evening as we staff up. But in the beginning, it'll probably be pretty close to clinic hours.
Currently, we have myself, and I'm a family physician. I'm an MD. We have an RN, Melissa, and 2 community health representatives. We just interviewed for hiring some more community health representatives, so that section is going to be growing. And then we have other positions that are coming open very soon for like a complex care manager, and we intend on hiring more nurses so that there would eventually be a 5-to-1 community health representative to nurse ratio. So the goal is to get out to 25 community health representatives. Wow. So it's really an opportunity for community members, if they're interested in serving their community in this way, to, you know, keep us in mind, because we will continue to hire CHRs or community health representatives over the next year or however long it takes us to staff up.
Now, CHRs, is that going to be like an entry-level position, or what kind of background would you want them to have?
Yeah, I feel like a CHR is an entry-level position if somebody didn't have a lot of medical experience but was willing to learn and was, you know, able to, you know, do the learning. You know, we're more than happy to have people that are relatively inexperienced. The big part is the commitment to the community and being able to be HIPAA compliant, you know, being able to maintain the protected health information that we're entrusted with and to not share that with anybody else. That's a really big, important part of the job. And then to follow through. Yeah, we really need to develop that trust with the community so that they will actually access care. So yeah, that's kind of a big thing. And then follow through. You know, we really want our CHRs and all of our staff members to really follow through on the things that are identified as needs. You know, we can't just survey and then go away and not take care of anything. We have to take care of things and, you know, of course, like prioritize things and, you know, that can I started like a lot of Native people start by taking care of grandma. So a lot of people do that in their own family. And my grandma had diabetes, so I was giving her insulin injections. I wasn't drawing them up, but I was putting them in somewhere around kindergarten.
Wow.
So I was just totally intrigued by this process, and I really like to do things like organize her medicines and things like that in elementary school too. She would of course tell me, put stuff. I wasn't like reading and deciding on my own like a nurse would nowadays or anything like that. But she was telling me to put up. But I just like putting the pills in the pill organizer. I like going to her doctor visits with her. I like listening to what the doctor had to say. So I just had an interest really young. I kind of thought that I was going toward science, hard science, rather than medicine. So I really, really love genetics and just molecular biology in general. So my first degree is in that. And I got that degree at Humboldt State. And so, I grew up here, went to college here, but then after I had my first baby, that's really what connected science to humans for me. Because before I had my baby, I really was just doing bench science, But after my first child, I was like, wow, humans. Humans all start like this.
Yeah.
And they end up in so many different ways in the world. And so if everybody starts like this, I have to help. I have to use science to help, when they kind of get off track with their health or mental health or substance abuse or homelessness or all of these different things that can go on in people's lives, to just try to use science in a good way to help humans. So that's really kind of what changed my mind to, instead of going to a PhD, going toward an MD instead. I had done some research programs at UCSF and the University of Washington in that PhD prep track. But I decided that I wanted to go to medical school, and specifically at the University of Washington because they have a Native American health pathway that trains medical providers to deliver care to Native populations. And it has special rotations and academic classes that are taken. So when I got into the University of Washington School of Medicine, I canceled all of my applications to everywhere else because I didn't want to go anywhere else. I wanted to go to the UW up in Seattle. And that school really supported me as a Native person. There were other Native people in the medical school. I was in a cohort of about 10. They were all female for some reason. So I was with
Big
10
Native community.
Yeah, so I was with 10 other Native female medical students. And we did community outreach there. We did an elders dinner every year for the Native elders of Seattle. We did a lot of stuff, so it was good.
Awesome.
Then I wanted to go to residency somewhere that had a connection to an Indian health clinic and was rural. Because rural care is different than care in a big city, at least in my profession in family medicine. Rural care is you do everything that you possibly can do. You really have a broad scope of practice with rural care as a family physician. So I chose to go to the Oregon Health and Science University's rural track out in Klamath Falls, Oregon. And that's very close to the Chiloquin tribes, to Chiloquin, where the Klamath tribe's health clinic is at. So I had an open door to do rotations up there and maintain some connection to a Native community while I was in residency.
Wow.
And then after residency, there wasn't a job out here. I wanted to come back home, but there wasn't necessarily a job open. So I just went to work for the Klamath tribes.
Wow.
And I worked for them for 3 years before I started working at United Indian Health Services. I have worked for them and the Cuduk tribe up in the Orleans Medical Clinic. And so it's always been really satisfying to work for Indian Health clinics. I've always wanted to work at Kamau. It just happened to be the right time and place